False positive, elevated beta-HCG in a male, a rare case of primary retroperitoneal choriocarcinoma in a male. Choriocarcinoma is a rare malignant, it's less than 5% of all germ cell tumors in males. Although germ cell tumors are primarily testicular, they can present in an extragonadal location, such as the anterior mediastinum, retroperitoneum, or pineal gland. Extragonadal choriocarcinoma has an incidence rate of 0.022 per 100,000 people. Early detection is very difficult, and patients often present with advanced symptomatic disease. Extragonadal choriocarcinoma yields a poor prognosis with a 5-year overall survival rate of 30%, which is much lower than that of extragonadal non-seminomatous germ cell tumors in general. Definitive diagnosis requires both exclusion of metastatic disease from a primary tumor in the testes and distinguishing an extragonadal germ cell tumor from another poorly differentiated cancer via biopsy and histopathological examination. Treatment consists of a cisplatin-based chemotherapy followed by surgical resection of any residual mass. The serum tumor marker, beta-HCG, is used to monitor treatment response and disease recurrence in patients with choriocarcinoma. Here, we present a case of a 24-year-old male with no significant past medical history who presented with left-sided chest pain and back pain radiating down his left leg. The pain started about 1 year ago but became worse over the past few weeks. The patient was a non-smoker and did not use alcohol or illicit drugs. Initial vital signs were positive for mild tachypnea but were otherwise normal. Physical exam revealed mild bilateral rhonchi on lung auscultation. Initial labs showed a mild anemia and an elevated D-dimer and lactate dehydrogenase. A chest x-ray of the chest and spine were normal. The patient then had a CT scan of the chest, which revealed innumerable bilateral pulmonary nodules concerning for pulmonary metastatic disease, as shown in Figure 1A. A subsequent CT abdomen and pelvis showed a large heterogeneous soft tissue mass compressing the bladder, as indicated by the yellow arrow in Figure 1B. This was consistent with the primary neoplasm arising from the left iliopsoas muscle. Pulmonary was then consulted for a CT-guided core needle biopsy of one of the lung nodules. Initial tumor markers were only significant for a very elevated beta-HCG of approximately 104,000. Pathology of the lung nodule revealed tumor cells that strongly and diffusely expressed human chorionic gonadotropin, as you can see in Figure 2, and this was consistent with the diagnosis of metastatic choriocarcinoma. Oncology was then consulted, and the patient was urgently started on inpatient chemotherapy due to the bulky nature of the tumor. The chosen treatment regimen was VIP, or cisplatin, etoposide, and ifosfamide. The patient completed 4 cycles of chemotherapy. As you can see in Figure 3, beta-HCG levels decreased significantly after each chemotherapy cycle and were ultimately reduced from 104,000 to 5. As you can see in Figure 4, restaging CT scans showed a good response to chemotherapy, as evidenced by the decreased size of pulmonary nodules. Risk factors that stratify patients with choriocarcinoma into a poor risk group include a retroperitoneal location, visceral metastasis, and elevated tumor markers. 4 cycles of chemotherapy is recommended for poor risk patients as opposed to 3 cycles for low risk patients. The retroperitoneal location of the tumor, presence of pulmonary metastasis, and very elevated beta-HCG levels placed our patient in the poor risk category. First-line therapy for choriocarcinoma is a cisplatin-based regimen with BEP, or bleomycin, etoposide, and cisplatin, or VIP, etoposide, ifosfamide, and cisplatin. Post-chemotherapy surgical removal of any residual tumor is then recommended. In our case, the patient was diagnosed with the poor risk stage 3C extragonadal choriocarcinoma and was subsequently treated with 4 cycles of cisplatin-based chemotherapy. Although VIP and BEP are both considered first-line therapy, VIP was chosen as the preferred treatment regimen to avoid the possibility of bleomycin-induced lung toxicity given the presence of pulmonary metastatic disease. Due to the poor outcomes associated with extragonadal choriocarcinoma, it is important to promptly and correctly identify this malignancy to initiate treatment in a timely manner. Although diagnosis yields a poor prognosis and this tumor type typically responds poorly to chemoradiation, treatment can potentially be life-saving, as seen in our patient. Given the rarity of extragonadal choriocarcinoma, there are not many actively enrolling clinical trials to provide treatment options, especially for patients who fail first-line therapy. Therefore, it is imperative to conduct more randomized clinical trials to better establish treatment guidelines in patients with refractory disease and improve survival rates.